authored by my friend Phil Barter from Australia. The hazard ratio went in the wrong direction. There was a 25% higher rate of major adverse cardiovascular events with torcetrapib compared with atorvastatin alone. Very disappointing. And in fact, there was a 58% higher risk of mortality. And so this really stunned all of us who believed at the time that HDL raising would work. Now, the reasons are unclear, but one of the things that we saw in our study, which was an intravascular ultrasound study of torcetrapib, was an increase in blood pressure of 4.6 millimeters of mercury. And clearly raising blood pressure is not a good thing to do, given the relationship of hypertension to outcomes. So we said, well, maybe torcetrapib failed because it had this adverse effect of raising blood pressure. And so along came dalcetrapib, the second of the drugs to be tested. This drug didn't raise blood pressure, but it didn't work either. The hazard ratio is 1.04. There's no evidence of a statistically significant benefit. The HDL raising was modest, 30 or 40%, but a lot more than niacin and no beneficial effects whatsoever. We studied in a trial that was organized by our group at the Cleveland Clinic, a drug called evacetrapib. And evacetrapib was even more effective. It raised HDL by 130%, and the average HDL in our trial reached 104 milligrams per deciliter. We thought this would surely result in a benefit. But in fact, the hazard ratio was 1.01, completely neutral, no benefit, p-value 0.85. It was a big trial, it was 1,500 events, and we saw no benefit. And then finally, the fourth drug, anacetrapib, long study going on for 5 years of this drug, and it did show a very small benefit that occurred after about 2 to 3 years, about 9%. But one of the things I didn't show you is that all of these drugs, with the exception of dalcetrapib, lower LDL cholesterol. They don't just raise HDL. And so, in fact, if you analyze the results of the anacetrapib trial, what you see is that this very slight benefit was entirely consistent with the modest LDL lowering effect of anacetrapib. So that it appeared that raising HDL had absolutely no benefit whatsoever. And so we've learned a terribly difficult lesson that this strategy for raising HDL just doesn't work. So we tried other strategies. We thought that if we could intravenously infuse HDL, either synthetically or naturally occurring HDL, that we could, in fact, produce benefits for patients. Now, we did a pilot study about 15 years ago with a variant form called ApoA1 Milano, but we've also, in more recent years, studied other ways of administering HDL intravenously. This is from our original study published in JAMA in 2003, a long time ago, 15 years plus ago. And it looked like it was working. But a lot of these patients weren't on statins. It was a very old trial, it was very small, and we weren't certain whether this would actually hold up in the modern era. And the answer is that it didn't. When we repeated the experiment a year or two ago, we published this recently in JAMA. What you see is the placebo patients actually did better than those that were infused with this synthetic HDL. And it's important in medicine, and for some of the young people here, don't be discouraged when you get a negative result. A negative result of a trial is every bit as important as a positive result. Publish it quickly, and tell people what doesn't work, just as we tell them what does work. And it just didn't work, and we told people that. There was a second product that we studied in parallel, and without getting into this, this is the Serenus HDL mimetic. Same thing happened. If anything, the placebo group did better than the group that got infused with HDL. Terribly discouraging, and it really showed us that even infusing HDL didn't reduce cardiovascular morbidity or mortality. Now, there's one more drug still in development. It's an Australian company. It's called CSL112. They're continuing their trial, but I'm not optimistic. We've had 6 failures, 4 CETP inhibitors, 2 HDL infusions, plus 2 failed trials of niacin. I am sorry to tell you this, it is time to give up on HDL. It's a marker for disease, but it's not a target. Now, interestingly enough, raising HDL with the approaches that we heard about from Professor Manchada and from Dr. Kapadia may make a difference. Exercise raises HDL, and I think there's some data in some of these other lifestyle changes, and that may well work, but drugs don't work. Well, what about triglycerides? Triglycerides, have had this strange relationship over the years where, it was important, then it was not important, and a lot of argument about triglycerides. I'm going to tell you what I think about triglycerides as a target to address residual risk. Now, this is a huge problem, I am aware, in India, that with just a little bit of abdominal obesity, South Asians get this metabolic syndrome with very high triglycerides related to small increases in body weight. And we know from a variety of studies, these are US studies, that, triglycerides, the relative risk of coronary disease is about as strong with elevated triglycerides as it is with elevated LDL. So the epidemiological data suggests that triglycerides are a valid target. And we have genetic data. So these are data, 2 genetic variants that are associated with lifelong reductions in triglyceride. And sure enough, those people that have low triglycerides for life on a genetic basis have a very substantially reduced incidence of early onset myocardial infarction. What we think is going on here is that there is a common pathway to hypertriglyceridemia that involves insulin resistance, which occurs with abdominal obesity. And these are all the things that happen with insulin resistance, but amongst them are high triglycerides and a more atherogenic, small, dense LDL that appears to have a greater likelihood of uptake by the arterial wall. Well, is there evidence that lowering triglycerides pharmacologically might work? An older fibrate, gemfibrozil, I don't think it's used anymore. It's certainly not used much in the United States. It may be used some in India, I'm not sure. Lowered triglycerides by 31% in the VA HIT trial, now published nearly 20 years ago. And in VA HIT, with the triglyceride reduction produced by gemfibrozil, non-fatal MI and CHD death went down, non-fatal MI went down, stroke went down, all the cardiovascular endpoints had a 20 or 25% improvement. So it is clearly promising data, not contemporary, not modern data in the statin era, but this is now in the pre-statin era when not a lot of these patients were actually on statins. Fenofibrate, the fibrate that most of us now use, was studied carefully in the ACCORD trial, and there was no benefit. And these were now patients that were being treated with statins. And so many of us said, well, maybe fibrates don't work if you give them to people who have already been treated with a statin drug. But what I want you to see here is that there is, and one always has to be careful about subgroup analyses because they can really be misleading. But in this study, if you look at in the box at the bottom there, that those that had elevated triglycerides and a low HDL, there was a benefit of fenofibrate. The problem with the ACCORD trial is they gave fenofibrate to everybody, not just people with high triglycerides and a low HDL, and it didn't work. But in the group that most of us would agree we would want to consider treating, it did work. This is now a meta-analysis. 5 trials of fibrates shown here. And at the top, in blue, you see patients that had both high triglycerides and a low HDL. And there's a 29% reduction in major cardiovascular events. In people that had neither high triglycerides nor a low HDL, no benefit. And so we think that one of the issues with these drugs is they have to be used in the right people. We have been interested in using omega-3 fatty acids. And it's a complicated story, and I'll try to summarize very briefly. But there is a trial recently, just within the last few months, published in the New England Journal of Medicine called REDUCE-IT, that used one of the omega-3 fatty acids, EPA, and seemed to show a 25% reduction in adverse cardiovascular outcomes. But it's a very difficult trial to interpret because the control agent that was used, the placebo, was mineral oil, and we know that mineral oil interferes with the absorption of statins. And so we're concerned that this benefit was due to toxicity of the placebo rather than the benefits of the EPA. We are running a trial called the STRENGTH trial. This is in people with high triglycerides, low HDL. We have 13,027 patients enrolled. We're in the advanced stages of follow-up. We're about 1 year from completion of this trial, and it's using a derivative of fish oil, omega-3 carboxylic acids plus a statin versus a statin alone. Now, let me tell you that we are reasonably confident that this will be a good test of whether or not the strategy of triglyceride lowering is going to work. I could end up eating my words, but I will predict for you a positive trial. So watch in a year or so from now in the New England Journal. We'll be ready to publish, and we'll tell you. And if it's negative, we'll tell you that too. But we hope it's going to be positive. Now, finally, let me just say that the idea of lowering LDL further is certainly a strategy for which there is very little doubt that it works. We have decades now of data. This is all a whole bunch of secondary prevention trials. And you look at LDL on the horizontal axis and the event rate on the vertical axis, and they line up along a straight line. Every incremental reduction in LDL cholesterol seems to reduce the coronary heart disease event rate. In fact, in the statin trials, where 2 statins were compared, one of them more potent than the other. So this is, high intensity statin versus moderate statin. There's a 28% reduction in major adverse cardiovascular events in this meta-analysis of now 5 separate large-scale statin trials. And so I think that's a pretty clear set of evidence. What's fascinating about the data is that a 1 millimole, 39 milligram per deciliter reduction in LDL had the same effect if you started at 135, as you saw if you started at below 78. That same delta, that same difference, has the same benefit of 22% across the entire spectrum of LDL levels, which suggests that there is no threshold for benefit. And that's why I've struggled with the guideline writers who have seemed to not quite get this. We have done a series, and we've now done 12 intravascular ultrasound trials, and we looked at all of the LDL levels in these trials. And there are very few things in medicine that line up along a straight line, but this one does. As you lower LDL, when you get to about 65 milligrams per deciliter, you start to see disease progression reach 0. And when you go below 65 milligrams per deciliter, you start to see regression. And so if we can get LDLs down below 65 milligrams per deciliter, we think that many patients will have less disease at the end of a treatment interval than they had when they began. And so this is pretty strong evidence. Now, we tested this recently with even a more powerful LDL lowering therapy, a PCSK9 inhibitor. And I want you to see how far we went. We published this in JAMA in 2016. We started with an LDL of 93 with statin alone. Then statin plus a PCSK9 inhibitor, we got to 36.6 milligrams per deciliter. I never thought in my career I'd ever see such low LDLs in a clinical trial. Some of the people were in single digits, below 10. And what happened is in those people that got to 36.6 milligrams per deciliter, we saw massive regression. We saw much less plaque at the end of 18 months of treatment in the coronary, measured by intravascular ultrasound, than we had seen at baseline. And so this strategy was highly effective. When we graphed it, you see that that relationship extends all the way down to as low as 20 milligrams per deciliter. So we see, and we saw no harms at these very low LDL levels. And so we think you can't have too low an LDL level. And in fact, if you want to really regress disease, get people to really low levels. And then finally, recently, the Fourier trial and others have shown that similarly, if you look not just at disease progression, but at morbidity and mortality, that getting LDL down with a PCSK9 inhibitor and a statin to as low as 30 milligrams per deciliter, which is what they achieved in Fourier, was associated with a very substantial reduction in cardiovascular death, MI, stroke, and hospitalization for unstable angina or revascularization. And in fact, if you look at just the hard events, death, stroke, MI, there was a 20% reduction. This is at an LDL of 30 compared to 93. So let me finish with this, I hope, very clear message. Our idea of what a normal cholesterol is has been colored by the fact that our modern society doesn't have the best diet in the world. If you look at primitive populations, Guatemalan Indians and natives of rural New Guinea, and et cetera, you see that 50 to 70 milligrams per deciliter is the typical LDL. If you look at domestic mammals, it's even lower. If you look at newborn babies, it's about 30. If you look at wild mammals, we think that the LDL level for which our species is adapted is probably a lot lower than we traditionally see. And so what we used to say is you can't be too rich or too thin. We now say you can't be too rich, too thin, or have too low an LDL cholesterol. Let me leave you with that thought, and thank you for your attention.
Thank you very much, Dr. Nissen.
Thank you so much, sir, for a very wonderful talk on cholesterol controversies. Now we are inviting you for the questions. Any questions?
Outstanding, Dr. Nissen, as expected. Just a question about HDL. There are two types of HDL now, functional and dysfunctional. And we know that there are certain studies to show that high HDL may be a risk factor. Did you have any idea of functional versus dysfunctional in these, by these? So, second question is, small dense LDL is a big problem for Indians with high triglycerides. Do you have any data on small dense LDL, which is responsible for disease in Indians? Thank you.
Well, those are two very, very good questions. I'm well aware of the research suggesting that the characteristics of the HDL make a difference. One of our colleagues at Cleveland Clinic, Stan Hazen, has done some fine work with this, and some of these people with really high HDLs do in fact have some kind of a dysfunction in the HDL. But I think it's still too early. We don't have clinical trials. We can't quite get a complete grip on that. Now, the problem with small dense LDL, if I had more time, I was going to go into that. But what's really interesting is you can predict very clearly who's going to have small dense LDL. If their triglycerides are elevated, they have an increase in small dense LDL. And so I think that this idea of triglycerides and small dense LDL is probably a very important concept, and I recognize it's quite important in the Indian population.
Finally, the PCSK9 inhibitors, I'm a big fan of that. Yeah. But do you have any concern if the LDL goes very low, less than 20? You said single digits also. Yeah. Can they get depression? There's some concern, depression or suicidal tendencies. Do you think it can occur?
So we've looked at it, and I didn't have time to show the data, but there was a trial called Ebbinghaus, which was part of the Fourier trial, where they looked at neurocognitive function at very low LDLs, and there's no adverse effects. And so I think LDL is a waste product. I think it has no functional value, and we have people in some of our trials. One of the trials we did called Asteroid, we looked at a group of people whose LDLs were less than 10, and they seemed entirely normal. So I'm not worried. I'm not worried about too low in LDL.
Thank you.
Sir, what could be the best way of controlling the LDL, because it is the culprit?
I'm sorry, I didn't quite hear that.
Sir, my question is, what could be the best way of controlling the LDL?
Best way to control LDL. Yeah. Well, my view is that we also have to consider, I love the PCSK9 inhibitors too, but they're very costly. And I don't know what they cost in India, but I know they cost more than most people can afford in the United States. So what I will tend to do is use potent statins in the highest possible doses. If I am not low enough, add ezetimibe, which is generic and inexpensive. And then for the very high-risk patients, to consider a PCSK9 inhibitor. If PCSK9 inhibitors were inexpensive, we would use them in large numbers of people, but they're not. And so this is where pharmacoeconomics clash with pharmacology. And I wish we could use these drugs in more people. But I think statins are great. Ezetimibe probably does some additional good, but the real problem is some of these people with heterozygous FH, we can't get their LDL down unless we add a PCSK9 inhibitor.
Any other questions?
Sir, does PCSK9 have any anti-inflammatory effect also? Because yesterday you said that we have to treat the inflammation part also.
So, yesterday I showed you our data on the anti-inflammatory effects of statins, which are actually quite profound. What's remarkable is that the PCSK9 inhibitors do not have an anti-inflammatory effect. And so, this is more evidence that statins are working by two pathways, by both LDL reduction and by anti-inflammatory effects, which I talked about yesterday. but it doesn't seem to happen with the PCSK9 inhibitors. No reduction in C-reactive protein, IL-6, or any of the other inflammatory markers. A bit surprising.
Dr. Nissen, thank you very much. Out of all the people who have been helped most is myself, because with 80 milligram of atorvastatin, my LDL remains 66, which I am not happy. I want to reduce it further. So I added ezetimibe along with that. I see the results. But I would like you to impress upon all these people who are here. They are so much worried about, they are asking you how, that there is no way better than using atorvastatin to reduce LDL as much as possible. And dose of 80 milligram is not a high dose at all as we used to believe it before. When it comes from you, it will have a very, very, very salutary effect, because all your talk, I learned from everything down from all the investigations. I am encouraged because I try to keep the LDL cholesterol very low as much as possible in all my patients. But and you have helped me as well. So thank you very much, because you really put an emphasis on a very, very simple thing, because as I told you, ultimately everything done, taking a pill is much easier than all the lectures that we can give. And atorvastatin is really a molecule of the century. And that's what I feel, and thank you very much.
Well, I agree with you, and I followed your pathway here. So I keep my LDL at about 50. And I want to be able to continue to work when I reach your age. But let me also say something, because I was asked to talk about pharmacology. I strongly agree with the perspective that you provided and Professor Manchada provided, that in fact there are these non-pharmacological interventions such as exercise, meditation, other things have to be combined with the pharmacology. You don't want to emphasize one over the other. You know, in America, everybody wants the answer to be in a pill because it's easy. You just take a pill once a day. But I think we have to do these other things, and we have to teach our patients that these other things are very, very important. Now, the final point I want to make is that 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin are very safe. Fear of statins is a disease in and of itself. And for the high-risk patient, don't fear statins. And for those of you that are interested, I wrote an editorial in the journal Annals of Internal Medicine about statin denial, people who deny the benefits of statins, which is in fact a really big problem in America. I think it may even be a problem here in India as well. And we can't fear these drugs. They have made, I agree with what you said, probably half of the benefits we've seen have come from these more effective therapies of LDL cholesterol.
May I add a small comment? For Indians, the dose of statins is much less.
Yeah.
And Dr. Didwania, we have also done study, 40 milligram is as good as 80. We have done and reported this recently.
Good.
That for Indians, the dose is much. Dr. Didwania did it long back, that 5 milligrams is equal to 20 milligram.
Yeah.
So I think the dose, high dose may be 40, not 80 for Indians. Large number of trials.
Yeah.
Thank you very much.
Yeah, if you get the LDL where you want it on 40 milligrams.
It's the same,
Yeah,
40 and 80. We did that.
Yeah, I think, you know, we know that. It's also true, by the way, in some other countries, like in Japan, they use much lower doses. So different groups of people with different, ethnic backgrounds are going to have a different response.
More questions. I want to thank Dr. Nissen for coming. It is just a great pleasure, a great honor, and just a most wonderful thing for us to have him here. Thank you again, Dr. Nissen. And we encourage a lot of young people to do research and do such a meticulous work and publish it. So thank you again.
Thank you for all your wonderful hospitality.
Ladies and gentlemen, we move ahead with the next presentation, and that will be a very interesting topic by Dr. Samir Kakaria. Basically, he's talking about the update of the management of the the period after the acute heart attack.